Maureen Njoroge, who's a consultant pediatric neurologist, joining us on set today. Karibu sana. Good to have you on the show. And then next to Dr. Maureen, we have Dr. Lucia Amolo, who's a consultant pediatric neurologist. Like I said, we have two pediatric neurologists there to really help us unpack this. Thank you so much, Dr. Lucia, for making the time. Good to see you. And last but not least, we have Mama Roy, okay? And this is Jason Nyambura, who is a mother to a child with epilepsy. Thank you so much for coming.
Thank you very
video
much.
As well. I really like how balanced the setting and the guest is, so that we really unpack this. But before we even talk about epilepsy and pediatric epilepsy, because like I said, this are conversations that we've had, for a very long time. This is a condition that we have seen for a very long time, but still there's a lot of stigma and fear. When you mention epilepsy, everybody thinks someone falls and then there's the convulsions and then that's it, right? But there's so many causes to it. But can we just understand, first of all, the brain, the structure, and so that when you're talking about epilepsy, at least we understand what part of the brain is being affected. Dr. Lucia, can we start with you?
Thank you very much. So to understand epilepsy, it's always very important to understand the brain. And when people think about the brain, they think about it being very complicated, but it's actually not too complicated. When you think of the brain, it's good to think about it kama engineer gari.
Okay.
So before a car can run, the engine has to be functioning well. If there's a problem with the engine, then the car may run, but it may not run so well, or it may just not run at all. So the brain controls everything that we do, how we talk, like we're talking now, how we walk, our personalities, how we perform in school. Every single thing that we do is controlled by the brain. So how does the brain do this? It usually passes signals from these little things in the brain called neurons. I don't know how many of you remember your anatomy from high school, but there are these little things in the brain called neurons that pass signals from one to another, almost like from A to B to C to D. So when you have a disorder in the brain, such as epilepsy, it's caused when you have abnormal passage of signals from one neuron to another. So these neurons are almost like firing too fast, very quick. So instead of going slowly from A to B, they're excessively firing, and this is what usually triggers a seizure. So the brain has several parts, and depending on where the abnormal signals are originating in the brain, then it can manifest in different ways. Like most of us are used to, the seizure where there's jerky movement. But actually, if you have abnormal signals from a different part of the brain, then it can manifest differently. For example, the back part of the brain is called the occipital lobe. It's responsible for vision. So if you have abnormal signals coming from there, you can actually just have abnormal vision. Like the patient may just say they're seeing stars, and that's how the seizure is. The front part of the brain is called the frontal lobe. It's responsible for movement, personality. So if you have abnormal signals arising from the front part of the brain, then you can have, what we're used to, the jerky movement or abnormal personality. The side part of the brain is called the temporal lobe. It's responsible for things like personality, what we call hemostasis. So if you have a patient having a seizure arising from there, then they may just present with abnormal behavior. For example, the patient may be jumping up and down, or have a sense of deja vu. So really, the brain is very important, and to understand epilepsy, we need to understand the structure of the brain.
Absolutely. It took me back to the class, anatomy class and whatnot. But Dr. Maureen, just to pick from there, so then epilepsy, how does it come about? Because you've talked about seizures and the abnormal sending of signals, all over the place. So epilepsy, in the simplest of ways, what is it and how does it come about?
Okay, so let's talk about epilepsy, and I'll pick it up from where Lucia has started from. So she's very well explained that to get a seizure, it's abnormal electrical impulses that are moving from one neuron, which is the cells of the brain, to another neuron. So, and then you have a seizure. And what a seizure is anything that seizes you, right? So anybody, you can say, you've fainted, you've been seized. But then now when we talk about epilepsy, we're talking specifically about an epileptic seizure. So this is a seizure that is secondary to these abnormal impulses being sent from one cell to another. So for us, when we talk about diagnosis of epilepsy, then we have to meet specific criteria. So for you to say that a child has epilepsy, then this child has to have at least 2 seizures, epileptic in origin, at least 24 hours apart.
Okay.
Yeah.
2 seizures.
Yes.
Of epileptic origin.
Yes.
Can we stick with that for a second? Epileptic origin.
Epileptic or yes. All right. So epileptic origin would mean that the reason why this child is seizing is not because, say, for instance, a child got a fever. Because we know that many children convulse when they get a fever, and that's not epilepsy. So we have to make sure that the seizure that they're getting is unprovoked. It's not because a child fell, God forbid, from like first floor or something. It's not because a child had a fever. It's not because of meningitis. It's just the brain itself that is producing these abnormal signals.
Okay.
Yeah.
All right. And then the third one was... Gosh, I've forgotten.
Right. So now in terms of epilepsy, there were 3 criteria. Yes, correct. So there was the first criteria where we say that the 2 seizures, epileptic seizures, have to be 24 hours apart.
Okay.
The second criteria is you have to have an epileptic seizure with a probability of more than 60% of getting another seizure. Yeah. So what that means is that the general public we all have a risk of getting an epileptic seizure, right?
Okay.
But then for us, if you have 1 seizure and a greater than 60% chance, then now we say that you have epilepsy. We categorize you like that. And how we know that you have a greater chance than 60% is if, let's say, you have some genetic conditions we're able to pick up out from examining the child. And then the third criteria is if you fit something called an epilepsy syndrome. So that comes from when, asking more questions from the parent and then doing a test called an EEG. Then I'll be able to say, okay, you have epilepsy because I'm able to categorize as a syndrome.
Interesting. You know what, because it makes me think, like when we were younger growing up, right? And like I said, we've seen this happen and we saw those jerky movements. And even sometimes someone just maybe convulsed because of something else, but we're like, yeah, kifafa, okay? And then we tend to run away because we didn't really understand what epilepsy was all about and what brought it about and how we can support instead of running away as children, right? But how common is it in terms of the numbers? What exactly do the numbers say? Because the global statistics say, 18 million, of the children are living with epilepsy. So do we have the numbers here in the country?
Yes, we do. I think I will speak specifically for, Kenya, but in terms of lifetime prevalence. So in your life, what is likelihood that these children will have gotten epilepsy in their lifetime? Yes. So unfortunately, in Africa, we have higher numbers than, in developed countries. And I think the worst of it is that the statistics in Kenya show that we are doing badly off compared to African, numbers. So what the lifetime prevalence is in developed countries would be about 3 to 5 children per 1,000 have epilepsy.
Okay.
If you compare that to Africa, about 17 children per 1,000 having epilepsy.
That's a lot.
And then for our own studies, it's 20 to 40 children per 1,000. So I feel like it's true to say that we have a higher burden of disease. And so for sure we need more advocacy for this.
Yeah. And we have patient advocate here who will tell us more about that. But also just aside from the advocacy part, this is a personal, journey for you as well, Fred, right?
Yes.
So can we just talk a little bit about that? Where did the advocacy come from?
Okay, my advocacy started while I was diagnosed with epilepsy. I was working in Iraq as a pastry chef, so I started getting convulsions, so I didn't understand what was happening. So until I came home and I went to do an EEG and an MRI scan. So when I did an MRI scan, it showed that I had a tumor on this side of the brain. So it's the one that showed that I was having epilepsy. So, but then I still couldn't understand, like, I'm 23 years old, how could I get epilepsy? What are the causes? Because I was still new, I was still fairly new. So I was given medication. I was given medication and told to go back to work. So it's only probably after like 4 years, after like 3 years in Iraq, when now I came home, there was a day I fell down from that day is where I decided now to do the advocacy, because while sitting down, because I'm living in Kiambu County, I saw there is no support group in Kiambu County to create awareness. The only support group that were there at that time were in Nairobi. So it's where that we decided as Kiambu, we probably have to have a support group that where people meet, talk, and express their own issues. Yes,
I see that. And when you say you started having convulsions, how frequent were they? And did you try to just understand what this is before probably coming home and going to a medical facility to get checked?
So luckily, we were coming for R&R after 6 months, so it was around the 4th month.
Okay.
So when I started getting the convulsions, a friend of mine from Uganda told me exactly, hii ni kifafa. So, but I was confused because first I thought maybe my aunt is following me in Iraq. So it's where now that the convulsions were coming like once maybe in 2 weeks, once in 2 weeks. So luckily I got enough time to come home, then now do the medication and everything, so that now when I went back to Iraq, I was now okay.
I see.
Yes.
Okay. And how bad were the convulsions, if you can remember?
They were, it depends. For you also to get more convulsions, it depends probably with the stress. And also it depends sometimes maybe you're walking and you're thinking a lot. So the convulsions were a lot, but with the medications, and sometimes in Iraq there was a lot of heat. Sometimes you are up and down getting more seizures.
Yeah.
Yes.
Okay.
Yes.
We'll come back and unpack how and what that meant for your job, because again, you're in a foreign country.
Yes.
Uko karibu na nyumbani, where you would say tutaita brother yetu ama cousin yetu akuje kae na wewe,
Yes.
You're in a foreign country.
Yes.
So what exactly did that mean for your job, and just the risk of just your day-to-day movements, and if it was impacted at all? But let's speak to Mama Roy. So, Mama Roy,
yes.
You're wearing purple. I missed the memo. The color for epilepsy awareness, yeah? But thank you so much for agreeing as well to come in and speak to us about a little bit about Roy. So can we go back to before you even went to the hospital and were given the diagnosis that this is epilepsy? Let's just go back to maybe the things that you noticed about Roy that, concerned you a little bit.
Okay, for me, I didn't give birth to Roy akiwa na kifafa.
Okay.
It started like akiwa 3 years old. Nikimzaa nilimzaa akiwa na ugonjwa inaitwa Epilepsy. Hiyo inakujanga during birth delivery. But for ya epilepsy nili notice akiwa 3 years.
Okay.
Alianza tu seizures. Then from there tukaenda kwa daktari. Kuna moja ilimpata ikampata was, ilikaa for kutoka saa 8 ya usiku hadi saa 3 ya asubuhi. That's when the doctor alisema kona epilepsy.
Okay.
From there the journey haijakuwa easy. It's been tough.
So first of all, Paul, like that must be very scary from 2 a.m. mpaka saa 3 asubuhi.
Yes.
So at this point, what is with the seizures, right? Because is it Dr. Lucia, Dr. Mourinho told us there are different types of seizures, not the kawaida one that we're used to, where there's the jerky movements or someone falls and convulses. But what was happening during this period? Was he alianguka kaconvulse?
Alikuwa tu ana converse kama ameangalisha macho juu.
Okay.
Then alikuwa na shiver. Yes.
Okay. So, Dr. Lucia, then can we understand the causes? Because from what Fred is saying is, he was fine. Then at some point he started convulsing. Then things, we Africans, they will think, hey, who ni nani huyu aliniangalia na macho ama ananifuata all the way to Iraq? And then Roy says, of course, the child was born with
Epilepsy.
Epilepsy, and then later on, epilepsy was also diagnosed. So a lot of people will struggle to really pinpoint and say, probably this is the cause of epilepsy. So are there like different causes, or it's just one and the same?
So for sure, there's a lot of stigma associated with the lack of understanding on the cause of seizures. Just what you're saying, uchawi. mtu aliniangalia vibaya.
You know, Iraq.
Exactly. So it is important to understand the causes, and the causes are so many.
Okay.
As Dr. Maureen had alluded to, one of the main causes is genetic epilepsies.
Okay.
So genetics is your DNA. Sometimes something goes wrong in your DNA that predisposes you to having seizures. Sometimes it can be familial, and that's why we as doctors, when we're taking a history, we like to ask, is there a family member who has epilepsy? Because if they do, then you may be predisposed to be having seizures.
Yes.
But sometimes it's just you. Something went wrong in your DNA and you got predisposed to having seizures. And they can occur at any age, you know, just as Fred was saying, at 3 years, at 23 years, so in childhood, in adulthood. Aside from that, commonly in pediatric patients, it can be birth injuries. So like Mama Roy was saying, for her child had Erb's palsy. So Erb's palsy sometimes comes about when you have a difficult delivery. So when mom is delivering, the baby is stuck. Sometimes if the baby doesn't come out easily, you have prolonged labor, then you can have injury to your brain because of the lack of oxygen to the brain. And that actually sadly is a common cause of seizures in Kenya.
Okay.
Other causes are trauma. We know road traffic accidents are so common in Kenya. Fall from heights. I'm always seeing kids who are falling from heights. If you fall from height, land on your head, you can cause head injury. And once you have head injury, you can be predisposed to having seizures. Infections are quite common in our setting. And the infections that we worry about are things like meningitis, or what you call encephalitis, which are caused by certain bacteria, viruses that invade the brain. And when they invade the brain, they can cause damage to the brain and predispose you to having seizures. There are other things that maybe the public may not be aware of, like what you call metabolic disorders, or what you call autoimmune disorders. So these are just a bit more complicated neurological conditions that can predispose to seizures. So the causes are far and wide. Even Fred mentioned tumors. So tumors, when you have any growth in your brain, it can be a tumor, it can be a blood vessel abnormality, such as an aneurysm, or what we call AV malformation, when the blood vessel is not formed well. So really the causes are quite wide. And when you come to a doctor, we try and take a good history so that we can understand what caused the seizure, because sometimes understanding the cause of the seizure can help with determining treatment. If you have a tumor, you can take it out and you have resolution of the seizures. If you have an infection, we can treat it, then you can have less seizures. Yes.
I see. And Dr. Maureen, are there maybe like early warning signs that we miss out, you know, either as parents, as family members, that probably could point to epilepsy, but we miss out? I mean, Fred said, I thought the heat and, you know, the running around and whatnot could probably lead to this.
So one of the commonest things that I see that is missed out, and usually what causes like a delay in diagnosis in epilepsy, especially in children, is that everybody tends to remember that, or to know the epilepsy that comes with jerking. So you know, everybody knows kifafa ni saa ile mtu anatingika hivi, all right? So the epilepsies are very different, and that's why I'm using the word epilepsies, is because the seizure types are very many and they're different. And so we've definitely, I'll speak on behalf of the neurologist, the pediatric neurologist, we definitely see very different types of epilepsies. And unfortunately, some of them, the parent is not even aware, or the referring doctor is not aware that this is a type of a seizure. So you can have something as subtle as, you know, a teenager coming to clinic and saying that anatingika asubuhi and keeps spilling the tea. All right. So subtle jerks that cause the child to spill things, or even when the child is younger, will just do a quick, you know, jerk. That's actually a type of an epilepsy. Others, unfortunately, are more severe. So you will have a child who maybe around 6 months of age, who comes with flexion of the body. So the head will go down and the arms will come down like this. It's a severe epilepsy, and then it will be mistaken for something else. Oh, the baby is playing. You know, things like that. Another common type, seizure type that I feel, you know, is also delayed is the one for staring. So you can have a school-going child, and then the child keeps staring in class. And then the mother comes and tells you that the reason they're bringing the child to clinic is because the teachers are complaining that mtoto ni mtundu. So she's come to see how can you help this child? You know, is there something wrong with the brain? Then you find out that this child is actually having these tearing episodes, are absent seizures, and is actually getting punished for something that is totally out of their control. So in terms of delay in diagnosis, it's basically because there are so many seizure types, and some of them are not well known, and so the parent and even the referring clinicians may take a bit of time.
To really explain what that is. And also still on a little bit on the cause, because again, majority of the times, again, like I said, growing up, you'd see someone, you know, with a seizure, and as kids, you would run away, and then you hear some parents say, you know, it's contagious, you know, and what utapata. So can we really unpack that? Because I think this is one of the things that contribute to the stigma, you know, when we're talking about epilepsy and pediatric epilepsy as well.
So yes, there's definitely a lot of stigma. So especially once you've given the diagnosis of epilepsy, there's stigma in very many places. The stigma in school is usually, you know, this child has epilepsy. Are we able to, you know, what activities can this child do or not do? So say for instance, you'll find a child who is no longer in activities because was a very good swimmer. Now they're not able to take the child for swimming because the teacher has said, because the child has epilepsy, we can no longer do swimming. So stigma comes really in different forms. And I think for us is, at least for what we do in clinic, we have to write lots of letters. So for this child who has been told, you can't go for swimming, you can't do this X and Y activity, especially in children who are very well controlled, then we have to write letters just to explain, look, this is a specific epilepsy type. We do not, we are really hoping that you can accommodate and make sure that the child is able to you know, do these activities. The other thing I feel that at least we're able to help to reduce the stigma is the child themselves, because they can also feel isolated. Just explaining to a child who's able to comprehend what we're talking about, that especially based on the age, that this is what is happening to your brain. Your brain is just overfiring. I had one child ask me, so that means that kichwa yangu inatoa stima mingi, so I'll be giving people shock. So
I think I've heard.
You've heard that one. Yes. So it's just explaining to them so that they don't feel that this is making them less than their peers, and also it includes them. So hopefully we're able to have less stigma. And find more ways to support, you know, other than judge. And remember, you were like, nodding your head, especially when you're talking about people, you know, running away or even shunning, saying, we are Caribbean, not. Have you experienced something like that?
Yes, of course. So many times. Like ukipeleka mtoto clinic, akona hizo seizures, uko kwa matatu, maybe uko kwa barabara ukitembea, unaona mtoto ana jack. Mtu anakuangalia zile za nini mtoto. Me I usually tell people, namuuliza swali, wanataka kujua nini inaendelea? Wanataka kujua ni nini mbaya? Niulize, nitakwambia. If he or she is interested, namuelezea.
That's a good thing, because you're passing on the awareness instead of just, you know, those ugly stares and especially people judging you. Sasa kwani mama wewe kwani hujui kunini mtoto?
Wanakuangalianga tu hivi, wanashindwa kwani haujui kuangalia mtoto. Maybe mtoto amepatwa na trigger, ameanguka. Wanakuambia wewe mama haujui kuangalia mtoto, na mtoto anaanguka. But deep down wewe unajua mtoto ni mgonjwa. But how hawajui.
And you also said the journey is not easy. It hasn't been easy. Can we unpack more on that? And we'll talk about treatment a little bit later on, but just your journey as Mama Roy, raising Roy, who has epilepsy.
My journey has not been easy, but nimekuwa na bwanangu amekuwa so supportive. Sasa amefanya at least safari yangu imekuwa rahisi. But the journey has not been easy. Shule, kumpeleka hospitali, nini, mambo mingi. But unafaa ukuwe strong kwa mtoto wako.
How old is Roy?
Roy, he's turning 13
Oh, wow.
on 31st May.
Oh, yay.
Yeah.
Okay.
Yeah.
So, and especially akienda shule, right? Did you have to explain to the teachers that this is, Roy's condition? Because Dr. Maureen, like you said, most of the times, when people don't understand, they will tend to think, mtoto ako na kiburi, mtoto hataki ku settle down and whatnot, and end up, causing more harm to the child, rather than offering them support. So, shule for Roy, what exactly does that look like?
Shule lazima uende explain kutoka from the head teacher na kwa mwalimu mwenye anamfunza na pia kwa watoto. Mi huenda kwa class naambia watoto Roy ako hivi, ako na epilepsy, anaanguka mkiona akifanya hivi. Yeah, lazima uambie. Yes.
Okay. What was the reception at first? Vile ulienda wait, so akienda shule ulienda kwanza explain. You didn't wait mpaka kitu ifanyike ndio explain.
Actually, mwalimu ndio aliniita.
Okay.
Akaniambia mtoto wako anashindwa na kuandika. Unaona kona abs palsy na imemwaffect mkono ya right. So anatumia the left hand. So teacher akaniambia Mama Roy, kulingana na venye nimeona Roy, anabaki nyuma kidogo.
Okay.
So tukaenda tukaongea na mwalimu, akarepeat baby class. Bado masomo haikumuingia. That's why nilienda kwa daktari, akaniambia bado Roy ako na intellectual disability. Hajui kusoma na hajui kuandika.
Okay.
So hiyo lazima uende uelezee mwalimu. Yes. Na waendelee kutoka hapo.
How interesting.
Yeah.
Because majority of the times when teachers don't understand, watashinda blame mtoto na blame the parent as well. So it's a good thing to at least explain that this is the condition and whatnot. And how has it been since uliambia mwalimu and you also took time, go to class, come here, learners, listen.
Yeah.
In the condition, dear Roy. So if you see him, doing this, it's because of this condition. How has the reception been?
Kutoka niende shuleni nikaambia mwalimu, everything has been running smoothly.
Okay.
Juu nao watoto wanaelewa Roy, mwalimu wake anamuunderstand. Actually Roy kwa shule yao hakuna mtu amjui the whole school. So everything is running well.
That's good.
Yeah.
That's really, really good to hear. And I think this is a call to action again for parents.
Yeah.
Especially wale wako na watoto wako na epilepsy, because majority of the times you want to protect them and shield them. Unafungia kwa nyumba, maybe wanafanya homeschooling, but no, just take them to school and explain.
Yes.
And explain to the teachers as well as the learners. But Fred, for you, so conversions started, in a foreign country. You didn't even know what that is until you came home, and got the diagnosis. There was a tumor which resulted to the convulsions. But when you went back with the medications, right, did it still continue? The convulsions, did it continue? And did you probably have time to and how did that impact your work?
So when I went back, the tumor was treated, but I was given medication because I was still seizing. So when I went back, I told my boss that I was having epilepsy, and luckily he understood because I was in pastry. So what he was doing, I was just making dough. Natengeneza unga and cakes. So sikuwa naenda kwa hot kitchen. So he used to understand me very well. So when it reaches a time, maybe he sees that I am not well, he tells me, hey, relax.
Take some
and
time.
ukae nje kidogo, because also at the same time we didn't want to tell the authority that I was not okay, because when they know you are not okay, immediately you will be sent back home. So my boss was also supportive. He was from Kenya. He was supportive when I told him about my condition. So what he did, he was just making sure I am not in the hot kitchen, or just making the dough, making sure the dough is well. Then after that, in case maybe he sees that it's too much heat inside the kitchen, I go outside, I relax. So it was a bit organized, I would say.
Yeah.
I would say it was a bit organized. Yes.
That's a good thing,
Yes.
to at least find someone who understands
Yes.
and supports you, because it's one thing to understand, but it's another to also offer the necessary support that you need. But I'm also just thinking, when we're talking about pediatric epilepsy and adulthood, because yours was diagnosed pretty much when you are an adult, are the presentations the same? Are they different? Yeah.
So the presentations, there are some specific seizure types that actually just are in children.
Okay.
So for instance, the example that I gave where the head just moves down and the arms move down. So it's an infantile spasm and it's specific for the children.
Okay.
For sure you can have different, but otherwise largely you can have seizure types just being the same in childhood, and even the childhood epilepsy is continuing to adulthood. So they can be the same, but there are some that are specific for childhood. Yes,
I see that. And also with the presentation, Dr. Alicia, because most of the time we tend to assume it is something else other than, oh, maybe I had a stressful day, or maybe the heat was too much, or maybe the kids alianguka, like we tend to think it's something else other than, right, epilepsy. So at what point, say, should parents be concerned and seek medical attention as soon as possible?
Okay. I think as long as you notice something different in your child, you should seek medical opinion. What we really advocate for in kids is to take videos. We tell the mom, just take a video. If there's anything you feel is quite unusual, take a video and come with it. And then we're able to look at the video and try and determine whether or not it's a true seizure or something else. Because kids can have many movements that are not actually seizures, what you call functional disorders. Probably the one that we'd be most familiar with is something like hysteria that usually happens in some schools where one child gets this and then soon like the whole high school is doing that same thing. So always having some sort of video can help us distinguish whether or not it's a true seizure. But for a lot of presentations, they are classical. The absence seizures Maureen mentioned, where anazubatu, that's classical. The epileptic spasms that she also mentioned, that's classical. So right away, we do know that it's a seizure.
Okay. Also, Dr. Maureen, you said almost all of us are at risk of epilepsy, right? It's one of those things we don't think about. But can we unpack a little bit more so that the next time we see this happen to, say, either our children or, a friend or a neighbor, at least we understand anybody could be at risk, because majority of the times we just think, that one runs in Yakina Nani's family, that is not ours, right? Yeah, so can we really unpack that more?
All right, that's, yes, unfortunately, we are all at risk. And we do not know, until you get your first seizure, that's when you're like, okay, I'm in this group, And the reason why is because, yes, there's, as you said, there's those epilepsies that run in families. So the time that maybe a member of the family gets a seizure, then they know, this runs in our family, and then that's why there's this other person so and so in the family who has a seizure. Now, what I meant by any of us is at risk is because we all have our own genetics. So in terms of genetic epilepsies are common, and so you can have a seizure happening at 3 years of age, at 20 years of age, unprovoked, older in life, older in age. So, and of course, the older we are, the higher the risks. You have hypertension, diabetes, strokes.
It's a lot of things.
Yes. So any of these things can also predispose you to a seizure. But even in the absence of these illnesses, we are still at risk. And so I think it's very important, as you've said, that we need to have advocacy and know that it can happen to anybody.
Anybody, yes. Yeah. And Fred, you also talked about support groups. And at that time in Kiambu, those Kukwana support group. Mama Roy, also want to hear from you as well. But we're due for a break. But before we go on a break, just a reminder of the question, that we're asking you this morning, and also go through a bit of the feedback before we go for break. So I'm just trying to find the question so that I don't read my own things, okay? But the question of the day is... there you have it on your screens. What is one thing you wish people or more people understood about health conditions? Let's look at some of your feedback on WhatsApp before we go on a break. So this one says, listening, very educative. And then says, I have a son who has epilepsy. How can he join the group of people with epilepsy? We are in Mombasa, okay? For probably if you know you know of a support group in Mombasa, probably you can direct them to. But this one says, good morning, Winnie and the panelists. Long time. Welcome back. Thank you. For me, I think personal health and mental health. When you have a question, is it true that you are not supposed to help someone suffering from epilepsy because people fear being affected? Which first aid can do to help such situation? Okay, Dr. Maria and Dr. Lucy, I think this is for you. And then this one says, hello, I have a 6-year-old girl with Dravet syndrome. Is there any medical help for her? And I'm just going to take a few pictures so that we remember the question. And then says, her doctor says it can only be managed. Okay. Then moving on to the other question. This one says, good morning. I am Clyde Mwendo from Machakos. If I may ask, I got some sort of epilepsy. I had of an injury in 2019 or in 19. I was told I had a clot in the brain. And then in 2023, I had my first convulsion. It lasted like some 50 seconds. I was seated in a plastic chair. I fell down, I woke up, and I had bitten my tongue like hell. I was hit by a stone on the neck. I went to the doctor. I was put on medication, Tegretol. I do not know when I will be free from the medication. I worked in Saudi, and now the doctor never told me when to stop the medication. I would love to go back to work. So stress and pressure because I got a family. Can the doctor kindly tell me what to do? Okay. Let's move on to the next question. Oh, this one has sent a video. Okay, are we able to play the video? If we can. All right. So, okay. All right. And I think you talked about it. That it then says, this is my daughter. She does this frequently. How can I stop this nodding? Because it's affecting her brain, and she started doing this when she was 6 months. I was told she has Lennox-Gastaut syndrome. Okay. All right. So this one says, hello, I am really enjoying the show and learning a lot, many things. And this is Narla. Okay. Oh yeah, this one says we're in Mombasa, so probably how can I join the group of people with epilepsy? Okay. All right. Do you have another one, or do we take a break? Okay, we're waiting for this one to. Okay. This one says, good morning. I have learnt a lot. The stigma should be addressed. People need to know that epilepsy is not contagious. Okay. All right. So probably let's take a break, and then when we come back, we'll answer. We'll answer those questions as well as take more of your feedback in terms of the question that we're asking you this morning, and that is, what is it that you feel more people should know about their health condition? Okay, so let's take a break. We'll be right back with more. All right, welcome back to the show, officially the second hour on this Wellness Wednesday. And the conversation today is specifically geared towards pediatric epilepsy. And we're talking about breaking fear and building understanding. And like we said, the conversation is very necessary. And that is why we have two pediatric neurologists right here on set to really help us unpack this, break the stigma and bring understanding to the conversation, all right? And the question that we're asking you this morning is very simple. And that is, what is one thing you wish more people understood about health conditions, not their health conditions, but health conditions? And somebody said their physical and their mental health as well. But what do you think? Engage with us on our social media platforms. So that is at NTV Kenya, both on Facebook, on X, and everywhere else, okay? And also on our WhatsApp number. And speaking about WhatsApp, just to recap a few of the questions that were sent in before we went on a break, just to answer them, and then we'll go through more of your feedback. So though I remember two questions. One was, are we supposed to help someone who has a seizure because they were told you're not supposed to, okay? So are we supposed to do that? And then as I find the other question, probably can we answer that one? Are you supposed to help someone with a seizure? And if so, what is the correct way to help? Yeah.
Okay, yes, for sure. You need to help a child having a seizure. You can imagine if it was you having a seizure on the street and everybody takes off, that would be quite sad. So yes, for sure, you need to offer help, but you need to know the correct help to offer, because if you offer the wrong help, then you can actually cause worsening of the seizure. So if probably you're walking in town or you're somewhere and you see a child or an adult actively having a seizure, you need to, number one, avoid overcrowding. I know us Kenyans love to run and stare and see what's happening.
Yeah.
So usually we want the person to be safe. So they should lie on a firm, flat surface. If possible, try and turn the patient to the side. Why? Because we want to ensure that their airway remains patent. Or rather open. When you're having a seizure, sometimes you can have risks like your tongue falling back and you obstruct the airway, so you may not be able to breathe. So if possible, try and turn the patient on the side. Avoid putting anything in the mouth. I mean, I've had parents, there's once I had a parent who the child was having a seizure with me and she was like, tumpatie maziwa, you know, running to give milk because that's what she knows. You should not do that. Do not put anything in the mouth because the patient can choke, which can cause worsening of the condition. Then if you need to try and time the seizure, so just look at the time when the seizure starts, because usually if you have a seizure that's lasting more than 5 minutes, then it's unlikely to stop on its own, and you need to call for help early. If it's someone who's known to have seizures, a lot of times they may have what you call rescue medication in their bag, so they may have some medication which you can give to stop the seizure. So if they're with somebody they know who's familiar with the condition, just ask, is there any medication that the patient has so that you can give to the patient. So generally that's first aid when they're having an acute seizure. So 5 minutes, call an ambulance, rush to hospital. It may not stop on its own. But there's also some long-term things that we need to do for patients who are known to have epilepsy. For example, you need to safeguard the home. For example, it's preferable that they have showers as opposed to, you know, soaking in a bathtub, especially if they have frequent seizures. What if they have a seizure when they're in the bathtub? Then they can easily drown. Things like open flames. Don't barbecue with somebody who has, you know, this atonic head drops like we saw in that video, because that can predispose the patient to having a burn wound. When you're in school, inform the school about the epilepsy, so that if, for example, they're in the chemical lab or they're swimming, then in case something happens, we can easily get help. And ideally, when they reach the age for driving, these teenagers, they need to inform, if it's NTSA, that they are epileptic patients, because there is a risk of having a seizure when they are driving. So there are some general first aid principles that we do say should be offered. So please offer help to that patient who's having a seizure. Don't run away.
Okay. This one says, good morning. I'm Clyde Mwendo from Machakos. If I may ask, I got some sort of epilepsy. I had a head injury in 19, and I was told I had a clot in the brain. And then in 2023, I had my first convulsion. It lasted some 50 seconds. I was seated in a plastic chair. I fell down. I woke up, had bitten my tongue, and I was hit by a stone on the neck. I went to the doctor. I was put on medication, Tegretol, and I don't know when I'll be free from the medication. I worked in Saudi, and now the doctor never told me when to stop the medication. I would love to go back to work. So stress and pressure because I have a family. Can the doctor kindly tell me what to do?
Right. Sorry, that sounds like a very, you know, that's a journey. So from what I've understood from the question is she's trying to figure out when she's going to stop the medication
and go back to work.
All right. So I will speak in terms of pediatric epilepsy because I'm not an adult neurologist.
Yes.
So the thing with pediatrics is that children tend to do better in terms of medication than adults. So for her specifically, I'll tell her, you know, I'm imagining this is an adult, then she needs to have clear follow-up with her a neurologist. But in terms of children, usually we have, for majority of the children, if you put them on treatment and they're able to stay 2 years without having a seizure, then we know that we can at least have more than 70% staying without medication after that. So the outcomes for children are really good. For sure we have the 30%. And in that group now we have the ones who have, let's say, structural brain injuries that, or the severe forms of epilepsies for which the treatment would go on for longer, or the genetic epilepsies that occur around teenagehood, which some of them are actually lifelong epilepsies. But in general, children, if you're able to stay 2 years seizure-free, then the doctor should be able to wean off your medication stop, and then should be fine after that.
Okay, I see that. And then there's one who sent the video of the daughter and said, this is my daughter, she does this frequently, how can I stop this nodding because it's affecting her her brain, and she started doing this when she was 6 months, and she was told she has Lennox-Gastaut syndrome.
So for Lennox-Gastaut syndrome is a type of genetic epilepsy. It's what we call in medical terms epileptic encephalopathy. So these seizures can present with different seizure types. Like the video that we saw was what we call an atonic head drop that Dr. Maureen had mentioned earlier. They can also have those seizures that we are familiar with, the generalized tonic-clonic seizures. So treatment for this particular type of epilepsy can be tough. We do a stepwise treatment. So usually we start with medical therapy, what we call anti-seizure medication. There are some that is recommended for this particular type of epilepsy, like what we call clobazam. Usually if we find that the seizures are very frequent, there are other therapies that we can use apart from the medical therapy, such as dietary therapy. So there's some specific diets that we recommend for patients who have drug-resistant epilepsy, what we call the ketogenic diet, which is usually high fat, moderate protein and low carbohydrate diet. It's shown to kind of improve the frequency of the seizures. And there are other forms of diet, such as what you call the modified Atkins diet. So we'd usually recommend such a patient work with a nutritionist. They can be tough to follow in pediatric patients because unamwambia mtoto asikule chipo.
I mean, listen, there's a preference.
Yes. Unamwambia avocado na nyama kila siku. It can be a bit tough to follow. But you have to do risk versus benefit, and it has been shown to improve. If they have a lesion that is amenable to surgery, there are some specific surgeries that we can do for this particular type of epilepsy, but it is a tough type of epilepsy to treat. So aside from the seizures, a lot of times we have to treat the comorbidities that come with that type of epilepsy. For example, they can have what we call neuroregression. So they go back. This child was talking, suddenly stops talking. The performance in school drops. They have even walking abnormalities, gait abnormalities. And it can come with other things like anxiety, depression. You can imagine having this type of epilepsy that's so difficult to treat. And remember, you're treating the whole family because it can create issues and difficulties for the rest of the family. The missed days at work, the financial burden, getting a school that would be appropriate for the child. So they need holistic management when it comes to managing these particular cases. So I just recommend that she sees a pediatric neurologist so that we can develop a good plan to follow up this child.
I see. And Fred, I think there was a question on support group in Mombasa.
Yes, there's a support group in Mombasa by Foundation for People with Epilepsy has a clinic in Mombasa, and also their patients have a support group there. So I think maybe they could reach them over there.
All right, I see that. Thanks, Fred. And also when you're talking about support, Mama Roy, let's hear from you, because again, like you said, the journey has not been easy, but you have a very supportive husband, which is really, really good to hear, because we've had so many families where some of the partners have actually run away, and one of the partners is left to take care of the baby. So when we're talking about support for you and for Roy, because like Dr. Lucia said, the whole family will be impacted in one way or the other. When one person is sick in the family, we all get sick, right? So what is the support that you have received so far, and what is the support that you wish people would give for you, say for your family, but most specifically for Roy?
First of all, the support is financial support. Kununua hizi dawa ni very expensive. Like for Roy anakunywa dawa za roughly 1K kila siku. So financial support ni mzuri sana. Bado tunataka mental support. juu kudili na mtoto ako na epilepsy sometimes amekuwa hyper, hataki kukusikiza, ni hectic. Also tuna need emotional support pia juu it's getting emotional. Juu the moment tunapeleka mtoto mahali mtu anakuangalia na shindwa shida yako ni nini, inaku irritate.
And sometimes people tend to blame you, you know, and yet you're here trying to do the best for your child, you know, offer them the best care that they can receive. So all forms of support, from mental health to emotional to financial. And when we're looking at financial, we'll also talk about insurance covers and does it cover, does it not? You know, because we all know how out-of-pocket expense, as far as medical, it's very expensive in the country. Yes, Fred?
I also wanted to add on what Mama Ro is saying. I'll also urge the men who are listening to me, because most of the women that come to our organization, 90% of them, their husband ran away. So it is important also, because the men say this thing, we don't have it in our family, in our lineage. So it's also important for the man to stay with the lady and walk the journey, so that they find the answer.
That they need. Thank you so much, Fred, for pointing that out. And just looking at your journey as well. So with the medication, you were able to go back to work, spoke to your manager, to your boss, and they were very understanding and offered you all the necessary support that you needed. But you're here.
Yes.
Like, did you now come back fully to run the foundation, or do you intermittently go back to work? And just take us through what your day-to-day is with the medication and just how you're doing.
Okay. Right now, I came back fully to run the foundation.
Okay.
The foundation, probably, we started it in 2018. The reason why we started the foundation is after my journey with epilepsy. So our main goal is to do advocacy, is to create awareness about epilepsy, go to schools, go to churches, talk about epilepsy, and also empower people with epilepsy. The type of medication I use is Keppra. So since I started using Keppra, I've stayed a long time without getting any seizures. So I would say first, if you take your medications well, take them on time, maybe eat well, and also make sure you don't have stress, because there is something called causes of epilepsy and triggers of epilepsy. So triggers is when maybe you've not eaten, you've not taken your medication on time, you didn't sleep well, flickering lights. So if you're a person living with epilepsy and you're taking medication on time, and also you know your triggers very well. Like me, I know my triggers. So if you know your triggers very well, I think you live a normal life. And the other thing is acceptance. Acceptance is the key. Because if you don't accept yourself, I took like 2 years without accepting that this is epilepsy. But after I accepted myself, and also the other thing also is support. Support is also very, very important. It's very, very important. Because if you find, that time I wasn't married. If you find, I was staying at my mom's place, so my mom really supported my journey, making sure I'm going to the hospital, making sure I'm not even sleeping alone because of SUDEP, things like that, making sure I eat on time. So if you have a family that supports you and takes care of you well, the community will respect you. But if your family doesn't respect you, even if you get a seizure, they just say, we know that person is like that. So it's also important for anybody listening to me out there, if you're maybe a caregiver, please take care of the person. Yes, very important. Yes.
Okay. Empathy. It's pretty much important for all of us, really. And Dr. Maureen, you also mentioned as a country we're not doing well. Right?
Yes.
In terms of the numbers and what the figures say. Do we know why? Because you see, President Alisema, we are middle, developing. So people would assume our healthcare system is better. We know better and whatnot. So why do we see this very concerning figures as compared to probably like other regions in the continent.
All right.
Yeah.
So in general, where we are doing poorly, I will speak as Africa versus the developed countries, is because we have specific conditions that are unique to us. And I think the problem is, especially as Dr. Lucia had said, issues surrounding birth. The problem would be if a mother is staying very far from a hospital. Say, for instance, this mother is pregnant, and is unable to get to a health facility to be able to deliver in a safe way. Then the chances of getting, a difficult delivery, a child who was not cried immediately after birth, would be much higher. And so one of the things that Africa is struggling with is having access to healthcare easily for people to, like the distance you have to travel to go to a hospital. So that's one of the things. The other thing that I think has put Africa a bit higher in terms of the numbers of epilepsies is because we have very many infectious diseases. So we have a higher burden of meningitis, a higher burden of cerebral malaria. So all these infections puts our numbers of epilepsy to be much higher, because even with good treatment, say for instance of cerebral malaria, then you still have a number of children who have brain injury after that, and hence the chances of them getting epilepsy is much higher. Now let's take this to Kenya. So the same thing that's happening in Africa is what is happening in Kenya. I think that the other thing is, for sure, the studies that we have are not that many. And that's why even when we are saying statistics of 20 to 40 children per 1,000, then we don't really know where we lie. And it's because we really need more studies to be able to narrow it down to, okay, so this is exactly what the prevalence is in Kenya.
And Fred, just coming to you, in terms of care, right? Because Mama Roy said it's not cheap. When it comes to the medication and whatnot. And from a patient, advocate perspective, are there things that maybe we can do better? What is the level of care, first of all, as far as epilepsy is concerned right here in the country, and from where you sit? What are some of the things that we can do to at least make it easier for parents who are raising children with epilepsy?
Thank you very much. The level of care, I'll say, is a bit expensive to a parent, because you'll find probably maybe you go to the hospital, you are given like 3 types of medications or 2 types, and you'll find that most of these medications are very expensive. And remember, almost half of Kenyans live on $1 a day. So some of these patients that come to our center, they ask you, do I eat or do I take medication? So they have to choose a struggle.
And even with the eating, there's a specific diet.
Yes, with the eating, like Dr. Lucia said, there's a special diet. I don't know, seizure avocado. So we are hoping, if the government maybe continues to roll up SHA very well, we are hoping probably in future they'll be including, and also with the Disability Act, we are hoping probably in future things will be better, whereby people will be accessing medication at any center, at any maybe level 1 center. They are not like going to the big hospitals. Yes. Okay.
All right. Mama Roy, anything else to add on this? In terms of like care and what we can do better, because you're raising Roy, you know where, the shoe really, really pinches.
Okay, thank you very much. Let me add up kwa support. Even as we have a support system, we have an organization. It's called Roy Ndungu Foundation. It's located in Kikuyu, behind Power Star Supermarket. Tuna deal na caregivers. We support caregivers and also people living with disability. So kwa kusupport, lazima to support community.
What is that one thing in the support group that watu wanasema ingefanywa tu leo our lives would be a little bit easier? What is like one of those biggest concerns from
the biggest concern, of course, kukaa na mtoto wako na disability ni medicine. Medicine is so expensive. Tukapata facilities, hata mahali tutaenda tu tuchukue hizo dawa bure, tutafurahia.
And also, speaking of that, because there was a time we were having a conversation about sickle cell, and one of the things that came out was there's not enough data. Because when you go to the government and say, hey, listen, people are suffering, okay? And to make it easier for them, you see the way we did with the HIV, medication and whatnot. And they said, they're told there's no data. So kama hakuna numbers, how do we know that this is the amount of people who need this kind of support? So I think Dr. Maureen, Dr. Lucia, this is for you. In terms of accessing the data and that data helping in informing decisions, say for example medication, if they can be subsidized or atazipeanwe for free, would make it easier for them. So I don't know, what do we do? Data to at least get this specific data. Yeah.
Well, for sure, we need to do more research in terms of epilepsy. As Maureen has said, there's so many cases. Unfortunately, some of them are undocumented. Yeah? There's no trace. They probably go to the traditional healer in the village and never get to a healthcare facility. Yeah. So we need to map out Kenya and start having a system for reporting all cases of epilepsy, because as you said, data is what usually speaks. Yeah. But aside from that, I think it's also important to have advocates. If you have that politician who has a child with epilepsy, they can serve as a voice. The influencers for the Gen Zs, they can serve as a voice and just let people know that epilepsy is there. There's a lot of work being done in the international forum that is trickling down even to developing countries like our own. For example, we have something called IGAP, which basically is several people came together, including WHO and other organizations, to try and come up with a roadmap over the next 10 years to have a way of improving care for patients with epilepsy. So there have been some meetings that are ongoing on that. We had one about 2 weeks ago with various stakeholders to just try and assist in bringing epilepsy to the map and creating awareness. So I think we're already en route to that. We are doing a lot of advocacy, and we are starting to do a lot of research work when it pertains to epilepsy.
Okay, that's a good thing. That's a good thing to hear. All right, so the question that we're asking you this morning, just, as we go through the feedback before we go on a break, is what is just one thing you wish more people understood about their health conditions? Let's get to see what you guys have to say on WhatsApp in answering the question of the day, or either asking your questions really as far as epilepsy is concerned, or just raising a child with epilepsy. Okay. All right. So this one says, I am Pastor John Okoth, Redeemed Gospel Church, Shianda, watching live from Shianda, Mumias. Says the discussion is very informative and important. Proud of Mr. Fred Kiserem. He will be joining us here this Saturday for an epilepsy awareness and medical camp. We have a CBO taking care of currently 78 people with epilepsy. The number keeps growing. Thank you so much, Pastor John. And yes, you'll tell us a little bit about that, what will be happening on Saturday. And then this one says, hi, I have an epileptic boy, now 25 years of age. He was on drugs since 2 years of age and started school on nursery stage, but could not continue up to now. He is on medication, Epilim and Tegretol, each 2 tabs a day. How can you help me? Okay. And then I think these are videos as well. Probably we might play them offline. I don't think so. Okay. And then this one says, good morning. I have a boy who has developed a writing problem, like hand shaking, and even sometimes he cannot write anything. Can that be epilepsy? Can you please advise me accordingly for possible solution? Okay. And then this one says, hello, thanks for the good job you're doing. My question is my child found to be epileptic? My child was found to be epileptic 6 years ago. He was put on medication for 2 years, and we have never seen seizures since. Do we assume that it is gone, or we keep on doing the tests? Okay, can we answer probably like one before we go on a break? Yes, Dr. Maureen.
Right. I can pick from Chandu. I can pick from the last one.
Yeah.
No? Okay. So this mother is talking about a child who has been on anti-seizure medication for 6 years. And the question is whether she needs to continue on the medication.
Yeah.
That's a long time, especially for having seizure freedom. I think that she definitely needs follow-up with a pediatric neurologist, because as we said, pediatric, the group pediatrics, the epilepsy types in this group of children, in children in general, usually tends to resolve and does very well when you've said 2 years seizure free. So for such a child, at 2 years of seizure freedom, we would have ideally reduced the dose and then stopped it. I'm saying this cautiously so that the mom can actually come to clinic.
Stop.
She doesn't stop. Because what we found is after giving this information, we have a few patients who come and say, you said we need to stop this medication after 2 years, and then they just stop, and then we have seizures and we have to recount, which is really a very sad thing. So I would strongly recommend that, let her see a pediatric neurologist, do a tapering, and then we see how
how that goes. Okay, all right, so let's take a break, and then when we come back, we'll answer more of those questions, but also answer one of the biggest questions that a lot of people would ask, and that is, can epilepsy be cured? So we'll also be answering that on top of answering all your questions. But just remember, the question that we're asking you this morning is very simple, and that is, what is one thing you wish more people understood about health conditions? We'll also go through your feedback after the break. Just stay with us. Welcome back officially in the last few minutes before we say goodbye on Wellness Wednesday, and today we're tackling pediatric epilepsy, and we're saying we're breaking the stigma today, and we're bringing awareness and understanding to the same. But most importantly, like we said, support and empathy is important. Do not run away, okay? Learn to offer support, but also the correct kind of support. Dr. Lucia said, listen, correct kind of support, and especially when someone has a seizure, or even a child who's having a seizure. What exactly do you do? Do not put things in their mouth. Most of us do the spoon. Is that acceptable? No. Okay, do not put anything in the child's mouth or in a person who's experiencing a seizure. Okay, so the question that we're asking is, what is that one thing that you wish people really understood about health conditions? But let's answer a few more that we took before we went on a break. So this one says, good morning, I have a boy who has developed writing problems like handshaking, and even sometimes he cannot write anything. Can that be an epilepsy? And can you please advise me accordingly for possible solution? Dr. Lucia.
So my advice would be that she needs to bring her boy for a clinical assessment, because usually we do a good history, we do a physical examination so that we can kind of know what's going on. It may be a seizure, like Dr. Maureen had mentioned. There's something called myoclonic jerks, where they're holding something and then it flies off. But it could also be what we call movement disorders. So movement disorders occur when you have damage to a different part of the brain, and the patient now just has, abnormal movements, what we call chorea. Sometimes it can be what we call a tremor. So a tremor is caused when you have a lesion in a specific area of the brain. So really we'd need to do a good history, physical exam, and videos, as we had mentioned earlier, and that will help guide us on what the diagnosis is and what further investigations that we need to do.
Okay, I see that. Fred, you'll be somewhere this Saturday. Is it Saturday or Sunday? Saturday. Yes. Mumias.
Yes.
Hey, what will be happening?
We'll be in Mumias in a place called Shanda. We've been invited by a CBO called Save Africa. That's a support group that has patients with epilepsy over 78. So we'll be going there to talk to the parents, talk to the people with epilepsy. We'll also be talking to CHPs, community health promoters, talking to them about epilepsy, and we'll also be partnering with a community hospital there, helping them about diagnoses, what to do when you have epilepsy. So it will start from 9 to 2.
Okay.
Yes.
All right. So watu wako Shianda.
Wakuje.
Okay. Umesikia watu wako Shianda mko Mumias. All right. But the biggest question is on treatment, right? And like we said, so there are different types of seizures. So I want to believe treatment is also different, or is it one and the same?
It is different, yes. So we usually choose treatment based on the seizure type, and we've said that there are so many different types of seizures. Generally, how we categorize seizures is whether the seizure is coming from one part of the brain or both parts of the brain.
Okay.
So if it's coming from one part of the brain, then we say you're having a focal epilepsy. If it's both sides of the brain that the cells are overfiring at the same time, then it's a generalized epilepsy.
Yeah.
So we have specific medication that are for generalized epilepsy, first-line medication, and specific for focal epilepsy. The problem that comes in that I think we've seen is that the choice of medication. And that's why we are actually doing pediatric epilepsy training for healthcare professionals. We've been doing this, as early as 2022 to try and inform other healthcare workers about the different types of epilepsies and the medication that they can choose. Because what we notice is that earlier on, the child would be started on a medication that is readily available, not according to the type of epilepsy that they have.
Okay.
And the problem with that is that some medication can worsen some seizure types.
Okay. So, and also, because I think a lot of people are asking, can I get off medication? Remember the one who said me, I need to go back to work. Do I stop this medication and whatnot? So what are some of the things that probably influences either the reducing of the dosage or stopping completely? But I know with the stopping completely, there's a bit of a fear that what if I stop and then it comes back? So I don't know, Dr. Lucia, some of the things that probably need to be put into consideration before either reducing the dosage or stopping the medication completely, so that people don't just stop. Because bacterial is 2 years of no seizures, you reduce on the dosage.
So it depends on a number of factors. Number one is the cause of epilepsy. Okay. Like the video of the mom who played of her child, Lennox-Gastaut syndrome, that tends to be a very difficult to treat type of epilepsy. So many a times you'll find that the child will have to be on anti-seizure medication even for life. If somebody has a problem in the brain, like there's been some sort of brain injury that has caused a kidonda, if I could simplify it, in the brain, then you're more likely to have seizures for the rest of your life. Okay. So really it depends on what the cause of the epilepsy is. We do try, as Maureen has mentioned, if you are 2 years without any seizure, then we never stop suddenly, we taper off. So we slowly withdraw the medication. And if we withdraw, there is a chance that the epilepsy may come back.
Okay.
Sometimes you may actually spend the rest of your life without having to go back on the anti-seizure medication. But we do try and come off the medication and hope that the patient will be able to stay off the medication for as long as possible, if not for life.
All right.
Yeah.
I see that. And Mama Roy, so remember we talked about diet as well, right? So just how are you taking care of Roy in terms of, yes, their medication? Because like I said, 1,000 shillings every single day, that's it's way out of reach for so many people. So how are you managing that? Do you have instances where, Sha, for example, is helping in any way? But also when it comes to diet as well, does he follow like a specific diet or whatever is available?
Thank you very much. There is no Sha. You have to dip in your pocket. For the diet, Roy anakula normal diet. Anakula kila kitu, but sana skari ndio tunampunguzia juu ya seizures. But kila kitu anakula.
Okay. And how is he doing so far? Because Masema nenda shule with the other learners now understanding his condition, they're able to support him. So how is he doing even in school?
So far so good, he's doing well. For now the seizures zimepungua. Anakupa vizuri na other kids.
That's really good to hear. That's really good to hear. And also still again on the diet, I'm just curious because so there are things that is this is dependent on the type of epilepsy one has, right? It's not everybody that has to be put on a specific diet.
Not at all. So usually we just advocate for a balanced diet. But the ones that are drug-resistant epilepsy, meaning you've been taking your anti-seizure medication and you're not improving, then we do advocate for dietary therapy. So it doesn't mean now that all epilepsy patients should stop eating chipona ugali. Yes, but we do advocate for general good health, so having a balanced diet is important.
Okay. All right. Because my next question was going to be, so what are some of this types of foods that is, recommended and others to at least reduce on? Mama Roy said sugar, umejaribu kupunguzia Roy, but generally for someone, who's raising a child with epilepsy or has epilepsy, are there things that maybe they need to at least reduce on, maybe put more, as far as their diet is concerned?
Well, For diet, not per se, but as Kisarem had mentioned, you need to look at the triggers, which can be a lot.
Yeah.
Something like missing a meal can trigger menses, hormonal changes, fatigue, flashing lights. So many things can trigger. So you need to know the kind of seizures that you have and what triggers the seizures. For diet, usually we just advocate for a balanced diet. Your vitamins, your proteins, your carbohydrates, a balanced diet, adequate rest, adequate exercise. And then now you need to work with a clinician if you're going to do the specific diets, because there's a way that usually we tailor it.
Okay. And also for exercises, people will be scared. We're like, what if, I exercise and then I get a seizure? So I think the thing is just consult before you try something, right?
Yes,
because it's more,
But an epilepsy patient can live a normal life. Just because you have epilepsy doesn't mean, you can't go for a walk, you can't go for swimming. You can do all those things just like any other person. It's just ensuring that you have good control of your seizures.
Yeah, and understanding your triggers. Okay, so can epilepsy be cured? This is sort of the questions that we, a lot of people would want to know. Can it be cured, or is it just management?
Okay, so I will answer that question in a roundabout way. So we said that epilepsy is when the cells of the brain overfire. So they are firing at the same time. So what this medication does is that it reduces the overfiring of the cells. So what it's actually doing is that you're preventing the seizure from occurring. We are not giving you medication such that when you have a seizure, then we give you medication, although there is that. But the medication we typically give is to make sure that the cells don't overfire. So we are preventing the seizure from occurring. The word cure is strong. So I will stay away from that one. But then if you're able to prevent it for 2 years, then you could say you're cured, but we'd rather not use that word, because curing means that it will never come back again. But then, as Dr. Lucia said correctly, that for sure, even if we have said that more than 70% of the children will stay seizure-free, we still have that 30% who may have a seizure occurring later. So we wouldn't want to give the information that, you're now forever cured. Yes.
Okay. And even we're talking about this during the break and said, say, a child with other neurological conditions, cerebral palsy, for example, or autism, and then maybe a child has, epilepsy in between. So what does care then look like for this child? Because I know there's some parents who might be scared to offer certain medication because, might contradict with the other medications that they're giving. Like, how do you manage that, balance that? A child with other neurological conditions, but then again has epilepsy.
So it has to be holistic care. So you never just, see a patient having a seizure and immediately give whatever anti-seizure medication. You really have to dive in and take a good history and understand the patient, as well as comorbidities that they may have. If they have autism, cerebral palsy, even, let's say, a HIV positive patient, because sometimes the drugs that they may be taking for one condition can interact with the anti-seizure medication. A HIV positive patient who also has epilepsy and is taking antiretroviral therapy, some of that, they can be what we call drug-to-drug interaction. So it can increase the anti-seizure levels, reduce the ARV levels. So you really have to look holistically, look at the drugs that you're giving the patient and decide what is best for that particular patient. And as we mentioned with epilepsy, it can come with so many other things, so many other comorbidities. A lot of them are hyperactive. They have what you call ADHD. They're running here and there. So you have to treat the seizures, but you have to treat the ADHD also. But you should also know that if you don't treat the seizures well, it can actually cause hyperactivity. So just looking at the patient holistically so you can determine the correct course of action. So usually we call it multidisciplinary in the medical circles. That means they're working with the pediatric specialist, they're working with the occupational therapist, the speech therapist, the nutritionist, so the parent, and then usually one doctor is at the center of it, and then you have to refer to others. Maybe a patient with cerebral palsy has very tight limbs, what you call contractures. You have to refer them to the orthopedic doctor. Maybe they're not feeding well. you have to refer them to the gastro doctor. So really it's a holistic, multidisciplinary approach when it comes to managing any patient with epilepsy.
Oh, I see. Can it be prevented? Dr. Maureen, are there things that maybe we can do to prevent epilepsy or,
Yes. So in terms of prevention of epilepsy, we would look at it from prevention of the causes of epilepsy.
Okay.
So for instance, if we're talking about structural issues with the brain, and one of them that we've been mentioning is something called birth asphyxia. So if the child is not able to get enough oxygen during birth, just right before or after birth, then they have damage to the brain, and then now they are predisposed to having the seizures.
Yeah.
So one of the ways in which we advocate for prevention of epilepsy is to make sure that there is good management of labor and delivery, and that's usually in collaboration with the obstetricians and gynecologists. So the first thing is for the mother to know that, you know, they have to be in hospital to have this delivery, you know, happen, and they have to be on follow-up in the antenatal clinic, and then during labor and delivery, just to have this discussion with the obstetricians, with the midwives, that there has to be good management of labor, because if there's good management, then we reduce these numbers of the children who come with birth asphyxia, and therefore we're able to prevent future epilepsy. So in terms of prevention of epilepsy is management of these conditions. Say, for instance, another condition that I will talk about is like cerebral malaria. Catching it early, giving appropriate antimalarials would cause less damage to the brain, and hence reduce your risks of seizures further in as the child grows. The same thing comes with issues like meningitis, so all these infections, which unfortunately, as we said, is what is making Africa have higher numbers than the developed world.
Than the developed world.
And maybe just to add on to that, you know, vaccines. There's so many vaccine preventable diseases. There's actually a vaccine for meningitis, and many of the common bacteria that cause meningitis do have vaccines that we give. And of course, we're living in an age with a lot of anti-vaxxers. So just helping parents understand the importance of vaccines and getting them on time can help prevent infectious causes of epilepsy.
Oh, I see. Okay. But also stigma, which I think is one of the biggest issues really that we have as far as epilepsy is concerned. So how do we fight it? Fred, how do we make communities understand and just empower communities around us to really understand epilepsy and not stigmatize, but really offer the support that is needed, either for the child and for the caregiver as well?
I think the way we can fight stigma is going to schools and talking probably to the lower classes about it, because the young kids normally don't forget a lot of things. When you teach them this is this, they are very, very keen, and they know this is happening, this is not happening. What I'm saying about it is that, like myself, I only knew epilepsy after I was diagnosed. So most of the people that talk about epilepsy is maybe they know a cousin who has epilepsy. Now they go deep to know about epilepsy. But if we talk about epilepsy, make sure that it's in the syllabus, and also making sure that people like traditional healers and pastors also come on board. Because mostly when a person is diagnosed, they either go to the pastor or the traditional healer.
That's true.
So if the pastor and the traditional healer, we come together with them and tell them about epilepsy, and also encourage, so that in case maybe if they get clients, their clients also could be going to hospital. It could be easier. And also other pastors, it's important for them also, if maybe they have a person who has epilepsy, it's important also for them to tell them, even if they're praying for them and God heals, it's important for them to tell them, go to the doctor. Because there's a reason Dr. Maureen and Dr. Lucia went to school for all those years to study medicine. So it's important for them to tell their clients, I'll pray for you, but eventually go to the doctor. Yes.
I like that. It's like a multidisciplinary approach. When you go to the traditional healer knows to tell you, go to the hospital, okay? Instead of, okay, I see that. Mama Roy, what would you say as far as breaking the stigma as far as epilepsy is concerned?
I would like to say we love each other and we educate each other. Yeah.
Okay. Love each other and educate each other. And you're doing that. When
Yes.
someone is giving you that stare, you tell them, do you want to know?
Yes.
Okay, this is what is happening and
Yeah.
whatnot. Okay, I see that. But also when it comes to like our policies, what is it that we need to do different? Either in terms of the approach, we talked about data and how also data is very important. But what are some of these policy changes that we need to make as a country to just help? Because again, like I said, we're not doing well, despite us saying we're doing very well. Okay, but we're not doing very well when it comes to such conditions as epilepsy.
Right. So one of the things we let me start from the positive.
Okay.
We're actually doing very well in terms of epilepsy training, and we've been training very many medical health specialists around Kenya in terms of management of epilepsy. One of the things in terms of policy and guidelines that I think we are working on with the Ministry of Health is that we are trying to get guidelines in terms of epilepsy management in children, because I think that one of the things that we had discussed about is choosing the correct medication for the correct epilepsy type. Because the problem would be if somebody sitting somewhere in a different county in Mombasa should be doing exactly the same thing for the same epilepsy type, even if you're from, say, Samburu. Yeah. So these guidelines that we're working on is to help so that we standardize care and we're giving the best care for the children. The other policies are in terms of integrating the medication into what is available in public health centers, in terms of so that there is not such a difference between I went to a government hospital and I was not able to get this medication, but I go to private hospital, I'm able to get the medication. So sort of saying that this medication is important, so it should be available in both facilities. And I'm happy to say that there are many organizations that are coming together to make this happen, especially with the Ministry of Health involvement.
Yeah, and also when it comes to acceptance, probably Dr. Alicia speak to parents and caregivers as well, because like I said, acceptance is one of the most difficult things, to get to. But then again, once you get there, then access to care becomes a little bit easier. So can you speak to the parents who are watching us this morning just about acceptance and why this plays a very big role when it comes to epilepsy care?
So acceptance is important because it helps in seeking early care. And we know that with early care, then you're likely to have better outcomes. So I'd encourage, as Kisirem had said, especially, when your wife is bringing your child with epilepsy to the hospital, accompany them. If the other siblings can come along, let them come so that they can be able to understand what epilepsy is and break some of the stigma surrounding this illness. Or it came from your side of the family, or this and this. So when the whole family comes together to support a child with epilepsy, then we are more likely to have good outcome. I think we also need to do more work when it comes to schools. So we have been trying to just teach people. We have good institutions like KISE that support us, which is Kenya Institute of Special Education. They usually help with school placement. So for example, if you have a child with epilepsy who has learning difficulties, they're able to map out which area of the county you live in and recommend specific schools, be it a special school or what we call integrated schools, or even a normal school where the child can go. So if you have a parent with epilepsy who's struggling to find the right school, there are institutions that can help. I think we're also trying to break the stigma, as Maureen had mentioned, by working with other stakeholders like the Ministry of Health to just ensure that we have systems in place that will ensure our kids get the care that they need.
Fantastic. All right, so we can answer probably like one round of questions as far as either the question of the day or the topic. But the question that we're asking you this morning is, what is one thing that you wish more people understood about health conditions? Let's see what you have to say on WhatsApp, if we have that ready, Philip. So we can answer more questions before we say goodbye in regards to the topic of discussion. All right, so this one says, hello, for an infant with drug-resistant focal seizures but a normal MRI, what clinical and diagnostic factors lead you to recommend early surgery versus continued medical therapy, and how do you explain the likely long-term developmental outcomes to families? Dr. Maureen, Dr. Lucia, you can take that.
Yes, so the first part of the question is why this child, this is an infant who has a normal MRI and has a focal epilepsy. So focal epilepsy meaning that it's coming from one side of the brain, the MRI being done to look whether there is a lesion on that side. So I would say that for that child, given that it's a child who's less than 1 year, an infant, we would probably need to redo an MRI when the child is older. Why? Because of maturation of the brain.
Okay.
So after 3 years of age, then we do another MRI because the structure of the brain turns from spongy to a bit harder, so we're able to see lesions better. So I would say that for that particular child, we'll wait a bit, then do an MRI and see whether there's still a lesion, there's no lesion, and then now have that discussion about epilepsy surgery.
Okay. All right. And then this one says, when should a seizure be considered a medical emergency? Okay, we'll answer that. And then this one says, question, is there a relationship between epilepsy and autism? And then this one says, hi, Winnie, the panelists. Thank you for the show. So educative. I have a niece. She is 10 years and she experienced convulsions twice. That's last year, December, and the other one was this month, and hers is 20 minutes. How can I get Dr. Luce's contact? Because I want to know more and help too. And then says some movements and lip smacking and hand rubbing. Okay. And then this one says, good morning, getting it loud and clear. I have a son who's suffering from epilepsy. He used to have a seizure, but after taking drugs for 2 years, he stopped. But he's now suffering from weaknesses in his body parts, including weak neck. And what can I do, please? And then it continues to say, what is the difference between epilepsy and cerebral palsy, and how can I treat cerebral palsy, I think? And then says, good show. Keep educating the views. Yes. Okay, so someone is asking for your contacts. Probably we'll give that as we say goodbye, but we have literally, a minute or so before we say goodbye. So the difference between epilepsy and cerebral palsy, is there a difference?
So cerebral palsy is a cause of epilepsy. They don't have the same definitions. So cerebral palsy usually occurs when there's injury to a growing brain. Usually, like we said, a newborn period or an infant, they suffer some sort of injury, such as at birth or an infectious cause. Then that causes damage to the brain, and that now predisposes the patient to having epilepsy.
All right. And then they continue to say they have a son who's suffering from epilepsy, who used to have seizures, but after taking the drugs for 2.5 years, he stopped, but he's now suffering from weaknesses in his body parts, including weak neck. What can I do?
So they need to bring in the patient for a good history and a physical examination. There are some causes of epilepsy that can cause weakness. For example, you can have a stroke, and strokes can occur in children. And if you have a stroke, then you can have some residual weakness on one part of the body. So they need to come in so that we can assess.
Okay. And then this one says they have a niece, 10 years, experienced convulsions twice. That's last year, December, and the other one was this month, and hers was 20 minutes. How can I get Dr. Lucia's contact? I want to know more and help too. And then they continue to say some movements and lip smacking, as well as hand rubbing.
Okay, so lip smacking can be a form of seizures that the patient is having. So if they're still having that, they may actually not be having good seizure control. So they would need to come to hospital so that we can optimize the treatment for this patient.
Okay, and Dr. Morini, like 10 seconds. Okay. When should seizure be considered a medical emergency?
Seizures are a medical emergency. If they last for more than 5 minutes, we call it situs epilepticus, and at 5 minutes, you should be in hospital.
I see that. Thank you so much for coming. I know this is a conversation that we need to have for the entire day, but thank you. Thank you so much for coming back today. Dr. Lucia Morlo, who's a consultant pediatric neurologist, as well as Dr. Maureen Njoroge, consultant neurologist, a pediatric neurologist. Fred Kiserem, atakuwa mumia Saturday.
Yes.
Who's a patient advocate, as well as Joyce Omboy, who is a caregiver. Thank you so much for coming by today. We really learned a lot, and I hope that we can continue this conversation online as well. So stay safe. God bless. My name is Umi Lubembe. We will stay tomorrow right here on your world. Same time, same place. But keep sending in your questions. We'll forward it to them, I promise.